Hi, I'm Kelly Cervantes, and this is Seizing Life, a bi-weekly podcast produced by Citizens United for Research in Epilepsy. CURE. This week on Seizing Life, we present a special compilation of previous episodes focusing on epilepsy surgery. For some epilepsy patients who are eligible for surgery, it can be a truly life-changing procedure, resulting in significant reduction or, in some cases, elimination of seizures. The path to determining eligibility and ultimately deciding to undergo surgery is a long journey of consultations, tests, and ultimately personal introspection and considerations. In this episode, we present the medical and patient perspectives from pre-surgery testing through recovery. We begin with Dr. Joffre Olaya, board-certified pediatric neurosurgeon at Children's Hospital of Orange County, who spoke with us at Epilepsy Awareness Day at Disneyland about surgical approaches to epilepsy and how the new ROSA robot is impacting those procedures. What makes someone a candidate for surgery?
There's a big workup that's done to determine if somebody is an epilepsy surgery candidate or not. First, someone with epilepsy would be worked up by an epileptologist, and the epileptologist would order an imaging study. They would get an MRI to make sure there's no underlying brain lesion that could potentially be causing the seizures. They would get an EEG or a long-term EEG or VTM, video telemetry, to see if they could lateralize or localize what part of the brain the seizures are coming from. In addition to that, we may get some additional studies such as a PET scan, a SPECT MEG, and these are all other studies that can be used to help localize where the seizures are coming from. And then at that point, and patients would also get a neuropsychiatric testing, and that helps us to localize any sort of deficits, and sometimes it can help lateralize seizures as well. And so all that information is then taken together, and typically we would meet as a group with a surgeon, the epileptologist, the neuropsychologist, the radiologist, go over all the studies, and then determine if someone is a candidate or not.
It sounds like in order to be a candidate, you really have to be able to zero in on exactly where what part of the brain those seizures are originating from.
Yeah. Ideally, but once we have the information, we come up with a hypothesis of where we think the seizures may be coming from, and there may be multiple different areas. And so to gather more information, then we can place electrodes directly into the brain or around the brain, either on one side or bilaterally, depending on the hypothesis, to then try to capture a seizure and see where that electrical activity is coming from.
And what kind of surgical procedures can be done in that case?
Classically, we would do what's called a craniotomy. We make an incision, we elevate the bone, we open up the dura or the covering over the brain, and then we place electrodes directly on the brain, in particular the areas of the brain that we're concerned with the seizures are coming from. But we can also place electrodes directly in the brain. So instead of doing a large craniotomy through a small, a few millimeter burr hole or opening, we place an electrode direct stereotactically, so using a special neuronavigation software directly into particular parts of the brain. And this is much better tolerated. There's less blood loss, less pain, and then we can still gather a lot of important information to help, again, try to pinpoint where the seizures are coming from. And so in order to do this, at our institution, for example, historically, people would use frames, and they're special frames, and you have to calculate exactly where you put the electrode in. But now we use a robotic arm, which is the tool that we use is the ROSA robot. And so prior to surgery, I can plan exactly where I want the electrodes to go. And then the day of the surgery, I basically make the small opening, I put a little bolt in the bone, and then pass the electrode down to the target, trying to avoid any important structures, any vascular structures, to prevent any bleeding or causing any damage to the brain.
And so is the ROSA robot that you work with, is that for diagnostic, or are you actually removing part of the brain using that robot?
Yeah, that's a great question. So as I was describing, in this particular case, it would be diagnostic, so it's to gather more information and figure out where the seizures are coming from. But once we figure out where the seizures are coming from, then we remove the electrodes, and then we have another conversation as to what the next step in treatment would be. And so potentially, if it's an area that can be resected, we would remove it. If it's a place that can be ablated, we could put a laser ablation probe and burn the tissue to give us a similar effect. or if it's in an eloquent part of the brain, some part of the brain that helps us with language, with movement, and we decide we can't take that part of the brain out, then sometimes we can put electrodes directly on or over the brain that are permanent electrodes that are then connected to a generator, which is called the RNS, and that basically detects the electrical activity on the brain, and then when there's a seizure, it'll send a signal to help stop the seizures as well. And so the ROSA can actually be used for implanting the electrodes initially. It could also be used to help target and place the ablation probe, or it could be used actually to place the depth probe if we're doing an RNS. So it can be used for a lot of different steps in the surgery.
Dr. Jeffery Loeb, the John S. Garvin Chair, Professor and Head of the Department of Neurology and Rehabilitation at the University of Illinois at Chicago, provided us with an in-depth description of EEG testing and how it is used to localize seizures. One of the ultimate end goals here is to try and localize where those seizures are coming from.
For surgical workup, that's what we do. Most of the time we do EEG, we put electrodes on the scalp with various adhesives to make them stick, sometimes stronger ones when we do longer term EEGs. So routine EEG is often anywhere from 20 minutes to an hour. You only see what's going on during that window that you're looking. So if there happens to be an electrical discharge within that short 20-minute period, you may capture it. If it happens 5 minutes after you disconnect the wires, you miss it. So during a routine EEG, we may flash lights. We may ask you to hyperventilate, breathe really hard until you get a little woozy. And those are things that can actually induce some of those abnormal waveforms. During the long-term studies, we'll make you stay up all night. All the things that you're told not to do because you'll have a seizure. We'll stop your medications. We'll make you stay up all night. We'll say, well, I only get seizures when I get stressed. So we bring that ex-boyfriend in there at some point and say, now they're stressed. We want to see the seizures while the EEG is on so we can characterize them, localize them, and make sure we're doing the best treatment.
So the EEG is completed. You have your data. How are you reading that data? How do you use that to then help treat the patient?
So we sit in rooms with computer screens and we click page by page by page by page. So each page may have about 15 seconds of the brain waves. If you are there for 24 hours or 4 days, there's a lot. Sometimes we click the pages quickly. We have people who are experienced electroencephalographers who read the EEGs, who have a lot of experience seeing the different waveforms and patterns. And then we draw up a report that goes back to the doctor and says, this is our opinion of what we saw. If we're lucky, we capture the epileptic discharges and or seizures that allow us to localize where they're coming from. The closer you are to an electrode that produces that signal, the closer in the brain that is. And because we put the electrodes all across the brain, say it's coming from your right temporal lobe, we'll see the electrodes on the right temporal area have a lot more amplitude of the signal than, say, the left side or other parts of the brain. And that's how we localize where the seizures are coming from.
Wow.
The other thing we do is we never do EEG by itself. We will do an MRI, we will do PET studies, we will do other studies that corroborate.
What is a PET study? Positron
emission tomography. So one thing we do is look at the metabolism of the brain. So you inject it with a glucose, which is food for the brain. And if its uptake goes higher or lower in some areas of the brain, you see that on the PET scan. And that can correlate with an area that has those epileptic waveforms. And when things are concordant, when you see the PET scan abnormality, when you see something on the MRI, like sclerosis or dysplasia, that is in the same location where you see the electrical signals, then you say, aha, we've got it, and we can go after it and do surgery and help that person.
Hi, this is Brandon from Citizens United for Research in Epilepsy, or CURE. For the 65 million people worldwide living with epilepsy, progress is unacceptably slow. At CURE, our mission is to find a cure for epilepsy by promoting and funding patient-focused research. Learn more at cureepilepsy.org. Now back to this episode of Seizing Life.
Epilepsy Foundation of Chicago Board Chair Howard Zwirn provided us with a patient perspective on surgery, describing his personal experience, from the initial determination that he was a candidate through his recovery process. You're going through and you're trying all of these meds and nothing's working. You're still having the seizures. When did surgery first enter the conversation as an option?
I think it was maybe around the 5-year time frame. My parents wanted me to get a second opinion at Mayo. And so we went up there, and after the 2-day session that you have up there, their first recommendation was to have surgery.
I imagine because they could localize where those seizures were coming from.
Exactly.
I know that unless you can localize that
Right.
place, then you can't be a candidate for the surgery. So you find out that you are a candidate. What goes through your head?
The first response was no. I just can't do it. It was just, I was so scared. And then one night, I had a grand mal seizure. And had to go, after I had the grand mals, the next day I went in and spoke with the doctors. And he said, my doctor, Howard, listen, I think it's really time that you consider having surgery again. You're a candidate. They know the area. It's localized, there's always the pluses and minuses, but I really think that you should be considerate.
What did they tell you in terms of what the risks were and what they thought, the cone of possibility was for, your outcomes?
There's always risk with surgery.
Of course.
In your brain, there's always a risk. But because of the testing that I went through, that if there were more concerns or problems with the left side, that the right side would handle it, because a lot of it is the rehabilitation that you go through about speaking and writing and doing everything that your brain just doesn't do at a certain point. And that is really a part of the rehab. So at that point, that was the risk. I felt extremely comfortable from the beginning after meeting the surgeons, and it was a joint decision, Janine and I, we said yes.
Okay, so you have decided to have surgery.
Right.
You're walking into the hospital. What is that day like for you?
We were very, very nervous. We had just found out that Janine was maybe a month into having our first daughter at the time.
Oh my gosh.
So, I signed all the paperwork, God forbid.
And you have a child on the way.
And we have a child on the way.
And you're having part of your brain removed.
And I'm having part of my brain removed. It's a lot of risk, a lot of concern. So the pressure, I was obviously not only thinking about myself, but my family.
Yeah. How long did the surgery take from beginning to end?
Right. So I believe it was approximately 5 hours that I, was under.
I don't know
Not
how
a
long
full
I
day?
would. Right. I don't know how long I would expect it to take to have that procedure done, but not excruciatingly long, but
Not a full day.
And so you come out of surgery, and then it's just sort of a waiting game, I guess, right, to see if it worked. Like you don't know immediately if it's worked.
Correct. I was in the hospital for approximately 5 to 6 days afterwards. That going through some testing, about, how you feeling, having to, use the facilities by yourself, can you walk, how far can you walk? They 5 to 6 days, went home.
Wow. And what was the recovery period like? Did you have to do PT, OT, speech therapy?
I did them all. I think that I was home I was off of work for about 3 months.
Oh, wow.
Right. And through that time, I was going through some physical therapy, speech therapy for approximately 2 to 3 times a week at the hospital, writing, all of it, because there's no doubt that it's funny to think about. You having trouble writing, having trouble talking, but after the therapy, I definitely got back into that. And it felt really good after 3 months of being at home.
And you haven't had a seizure since?
15 years it's been since the day I had surgery. I've had 2 girls, healthy girls, that it's been an incredible 15 years.
Surgery is often not considered as a frontline treatment for obvious reasons. The expense, the potential risks are incredibly high. But in some cases, it
could be considered one of the, first 2 or 3 available treatments out there. And I think that we're starting to see that wave change so
Right.
that it's not the last available option. Nothing else works, so then you try surgery, and you're starting to see that conversation shift a little, which is really
Right.
interesting.
I think it's a great, it's a great point to bring it up a little more in the beginning of it. So you're not waiting 5 years, or 7 years,
Well,
or
the amount of damage that could be done,
Right.
or the risks that you're taking just by living with seizures over that time.
every seizure has an impact on your system.
Yeah.
Every one, and so all the people that we know that, again, have a seizure, 10 seizures a day, 15 seizures a day, it just hurts them more and more and more every time. And so if surgery is one pathway to cut back on that, right, it's a better thing for the future, right, to hopefully make their life better in the long term.
The choice to undergo epilepsy surgery is a personal decision in which the patient must weigh the potential benefits and risks in careful consultation with physicians. For some, surgery can provide relief or even complete freedom from seizures. But for too many people living with epilepsy, there is no relief. Though we have made great progress discovering new therapies and medications, over 30% of those with epilepsy do not respond to traditional treatments. That's why CURE is dedicated to supporting patient-focused research to find a cure for epilepsy. To help us achieve our mission, please visit cureepilepsy.org/donate. Your support and generosity are greatly appreciated. Thank you.